Hi, everyone. Welcome back to Making Therapy Better with Bruce Wampold, the podcast where we give voice to the researchers, clinicians, and clients who are all working to understand what makes therapy work and how can we make it work better. In this episode, Bruce sits down with Dr. Julia Frank to discuss their collaboration on the newest edition of Persuasion and Healing, a groundbreaking book originally written by Julia's father and which has influenced generations of psychotherapists, including our host, Bruce himself. Dr. Julia Frank, MD, is professor of psychiatry and behavioral sciences at George Washington University Medical Faculty Associates, where she's also director of medical student education and psychiatry. Julia is a psychiatrist, educator, and humanistic clinician whose career bridges trauma-informed care, reproductive health, and physician education. She directs the Five Trimesters Clinic for pregnant and postpartum women, and she has been a long advocate for integrating psychotherapy into medical care outside of traditional psychiatry, especially surrounding reproductive health. Julia's work is rooted in a non-dogmatic mind-body perspective that builds on empirical observation, cultural context, and the power of human connection. Now, as the co-author of the 2025 edition of Persuasion and Healing, Julia brings a tremendous amount of personal and professional integrity and experience to really enrich the legacy of her father's most enduring contribution to psychotherapy. Your host, Dr. Bruce Wampold, is a leading psychotherapy researcher and developer of the contextual model of psychotherapy. Bruce has trained clinicians worldwide and published over 400 scientific articles. He most notably co-authored the Great Psychotherapy Debate, The Evidence for What Makes Psychotherapy Work, a foundational text in the field as well. Check it out if you haven't read it. For Bruce, helping update Persuasion and Healing with Julia and the other co-authors is a full circle moment and a highlight of his long and distinguished career. And we all know how much he has gone on to contribute, so that's really saying something. Together, Bruce and Julia reflect on what has changed in the field over time, what has stayed the same, and why the foundational elements of healing remain vital, maybe more vital than ever, in our modern approach to psychotherapy and psychiatry, which is really dominated by diagnosis, medication, technology, AI, etc. This conversation is about legacy, and it's also really about where we go from here. Today's podcast is brought to you by CarePath's EHR, a practice management and electronic health record system with integrated measurement-based care, telehealth, and HIPAA-compatible AI-assisted progress notes. Research shows that therapists can get better outcomes today through measurement-based care, and with CarePaths, that's never been easier. Head over to carepaths.com now to learn more about how we can help you to make your therapy better. Okay, and with that, we'll tune in for this very special episode with Bruce and Julia. Please like, comment, subscribe, share this episode. We're really trying to get this dialogue growing so that we can all work together to make therapy better. We'd love to hear from you, suggestions about future episodes, reactions to this episode. You can find us on Facebook, Instagram, YouTube especially, etc. So check out the links. Check us out at carepaths.com, at makingtherapybetter.com, and we really just hope to hear from you.
Okay, we're ready to get started then. So Julia, it's great to talk to you today. We've collaborated over the last, maybe it was 2.5, 3 years on the updated version of your father's book, well, your father and your book, Persuasion and Healing. And I have to say, as an introduction, when I started my Ph.D. work, I was searching for someone who talked about psychotherapy in a way that resonated with me. I wasn't trained in psychology. I came from mathematics and the sciences, But I was looking for a more humanistic approach to the endeavor. And when I came across Persuasion and Healing, it changed how I understood psychotherapy. It was absolutely brilliant. And what's interesting, over the years, when I mention persuasion and healing to people of my generation, even very orthodox CBT people, Thomas Insill did the introduction to our book, and he said the same thing. It was a defining source for their professional development. So it was when we got together to do the revision, was a real opportunity to get to know you and vicariously your father. So I want to start off our discussion by talking about your father and how he came to write such a groundbreaking and seminal piece. So, talk a bit about his background and how he came to persuasion and healing.
Thank you for asking the question. And it's great to see you again, too. And many people have the same reaction that you've had. All my life, people have come up to me and said, are you related to Jerome Frank? And I think my father, and they'll go on about what this book has meant to them. He came to it he was quite old by the time the first edition came out. He was already in his 50s, but his background really began with some psychopathology in his family because his brother was quite ill and was hospitalized at Chestnut Lodge and subjected to daily psychoanalytic psychotherapy and remained so suicidal he couldn't leave his room for a year. And my father came from a background of sort of New York intellectual Jews for whom Freudian thought and psychoanalysis was part of the culture. But it sure did nothing for my uncle. And my father took him to New York and he got ECT and he recovered remarkably. So that was kind of light bulb went off. But my father had a very humanistic education, I guess. He went to Horace Mann School. He was always loved literature and so on. And when he got to college, he started studying psychology and he thought he might go into medicine, but he decided after someone took him to the recovery room and saw all these people throwing up and upset after their surgeries that he wasn't really up for that. So he decided he would go into psychology and he went to study in Germany with a psychologist named Kurt Lewin. And Lewin was a social psychologist. This is different from clinical psychology, behavioral psychology. It was all about what do relationships mean, but both in the focused sense and in the broader sense, how they affect people and their behavior. So then my father came back to the United States and realized he really did want to be a physician. So he went to he graduated from medical school, did a medical internship, and came to Johns Hopkins. And that was a huge step because what was going on at Johns Hopkins at that time, remember that psychoanalysis was still the paradigm of mental health care in this country. Not entirely. There was always the state hospital tradition and the sort of lunatic management tradition, but people who were not that disordered, psychoanalysis was kind of the only wheel in town, except at Hopkins, which had one of the first, I think it was the first medical school to even have a department of psychiatry. And the chief of that department was a neurophysiologist who had come through the state hospital tradition and but was not an organicist, I guess. He wasn't an organicist, but he was sort of interested in how the total environment, and he was a Swiss guy. His name was Adolf Meyer. So he was very interested in the effects of culture and the hospital environment and the environment and sort of on people's psychology. And that was the beginning of my father's residency education. Now, Meyer retired and his own way of approaching this, although it led to a very interesting sort of hospital-based treatment where everybody, the nurses and everybody were considered equal with the doctors, and people were very interested in patients' behavior and so on, not just their symptoms. but he wasn't able to communicate clearly what he really thought about people. He was essentially a neuroscientist, and he thought that way. So anyway, my father finished his residency, and then came World War II, and Hopkins sent a whole bunch of people in a unit called the Hopkins Medical Unit to the Pacific, and my father went with them. And while he was there, he was essentially an army psychiatrist treating, healthy but shell-shocked or traumatized or discouraged or disheartened young men, by and large. And he wasn't taking care of the kind of hospital patients that Meyer and his unit were working with. He was taking care of soldiers. And he came back, and it was there that he learned about group therapy, because that's what the Army did. They were still sort of psychoanalytically oriented, but they couldn't treat people, soldiers, certainly, in that mode. And they didn't want to. I mean, the psychoanalysis had been somewhat discredited by its military, the effect of on military recruitment a while back. So anyway, so he was in the Pacific for 3 or 4 years and became very interested in group therapy, but also in what happens when soldiers are demoralized and how they become physically ill, and also what they look like psychologically. So he comes back to the United States, and this is when, and he first worked for the Veterans Administration, and he worked with Florence Powdermaker, who was a psychoanalytically oriented group therapist, pioneer of group therapy. And they worked together, and that really kept him engaged. And then he reapplied to Johns Hopkins as the faculty. And so the year I was born, they all moved back to Baltimore, and that's when he started in Hopkins. Anyway, I'm giving you a lot of detail, but I think you'd like
No,
to know, right?
This is fascinating. I mean, the background is so important to understand.
I think that's true with my father. I think it's true with the patients we see. I think it's really critical. Anyway, so he gets to Johns Hopkins, and this is around the time that the NIMH really gets into research funding in psychotherapy. The NIMH, as we know it, doesn't do that much anymore. But at the time, again, psychotherapy was basically the only wheel in town. And there's a whole cadre of people coming out of the military, not just my father. I can't remember all. And Eisenberg, Leon Eisenberg was one of them for sure. And oh gosh, there's so many of names he's talked about for years, but I can't remember. But anyways, Guttmacher was another. So he was able to get grant funding in order to study psychotherapy. And his first study compared relatively intensive, psychoanalytically oriented individual psychotherapy with group psychotherapy. This was randomly assigning people to those two conditions. When I came to the Hopkins Clinic, again, these were still ambulatory, not desperately ill, but often quite troubled people seeking treatment from Johns Hopkins, which was this kind of mecca of medical care, both for the privileged people of Baltimore and around the world, and the not so privileged people. So he had a tremendous pool of people, diverse pool of people to work with. And what they found, and they went into this, I think, not knowing what they were going to find with that study. But what they found was that the outcome was completely separate from the method. So group patients with minimal therapy, patients with fairly intensive therapy, all got better or worse to the same degree. And in those days, you could make assumptions fairly broadly, and this confirmed my father's experience with the military population that he was familiar with. And so they refocused their research on not whether psychotherapy works or not, but on what is it about psychotherapy writ large that accounts for this, what's called the equal outcomes phenomenon. And that was a pretty provocative thing to say back in the day, but it has stood the test of time over and over and over and over. Mental health research or psychotherapy research tries to find some specific or lever to change some specific thing, and they end up with equal outcomes. The placebo and the wait list controls, not the wait list controls necessarily, but the placebo conditions or the comparative conditions do as well as the active therapy. It's like if the Washington Generals keep tying with the Harlem Globetrotters, and it bothers people because in our sort of worldview, we want to look for specific treatments and be very professional, but it doesn't hold up. So anyway, for all those, so that started that he had a quite he brought a bunch of research people with him from Washington when he came, including the first African American Ph.D. psychologist who ever worked at Johns Hopkins, a man named Earl Nash, John Gleitman, Stan Inber, a lot of people whose names aren't as well known as his, but they worked together for about 20 years, getting steady funding from the NIMH, and they both they did a lot of psychotherapy studies, but because everyone, including my father, but in addition to my father, was trained in psychological experiment, when they identified something that they thought was important, they could then subject it to some kind of psychological test. So, for example, they thought teaching people, orienting people to what to expect before they go into therapy might be why some people get better quicker, or that the expectation of getting better was common across all therapies, and that seemed to be maybe a powerful variable. So they studied it. They were able to do these random assignment studies where half the patients would be oriented to treatment and what to expect from treatment and what they were expected to do, and the other half walked in cold. And in those days, I was trained by a lot of psychoanalysts, and they used to say, person walks into your office and you should say, how can I help you? And then stop, and then let them talk, and eventually you inculcate that, you induce them to free associate and so on. But it was considered to be absolutely wrong to orient people and tell them what to expect and what you were going to do. But it turned out to be a very useful thing, that people did better if they were prepared.
Yeah.
Now, at the same time, there was in this era, behavioral therapies were coming up as well.
Mm-hmm.
And there, again, there seemed to be particular elements of the behavioral therapies that seemed to be particularly helpful. And so they did, and it seemed to be mostly getting people to do things. People learn not just by thinking or talking or relating, but by doing. And it's, overcoming behavioral avoidance was for both the mood disorders and the anxiety disorders that were being treated with behavioral therapy seemed to be a very important thing. And again, my father's group, did various kinds of studies or reviewed. But at this point, he was on all these study sections. And so, he both reported on his own group's work, but he went to meetings all the time. He learned about what other people were doing. So, and then, he had a lot of information from various sources, from experiment, from observation, experience, but also other people's experimental work. And he was teaching at the time. He was teaching Johns Hopkins Medical School, the second year class, course in psychiatry. And he really wanted to put it all into a compact format that made it accessible to people. He felt like he really had some very interesting insights, and he needed to share them. And he got a fellowship at Stanford at the Advanced Institute for the Study of Behavioral Sciences, which was for a year, to write the book. And while he was there, he met anthropologists who had studied healing and psychological healing in shamanistic protocols, I guess you'd call them, but also and Chris is out in California, and there was all this kind of flaky stuff going on with est and psychology, and cults.
Yeah.
And California's my father's family come from California, and he always said it was always sort of drawn to some of that looseness that California versus the East brought into thinking, or flexibility, I'd say. So anyway, he got really interested in how what we call psychotherapy shares elements with these other forms of psychological influence. And so when the book was finished, it had almost a theory of what psychotherapy is and does, even though my father was, sort of allergic to theory if it was if the theory itself became sort of a distraction, or was too much internal and not based on what you could do and see. But he can't with a theory about what are called now the common features of psychotherapy, that arousing hope, giving people opportunities to learn and practice, and other corollary things, really is what makes psychotherapy work. And all this is embodied in the therapeutic relationship. Now, this is really interesting because nowadays, a lot of therapeutic relationships are with, AI or with people who you see remotely. But the book goes on in great detail about how you establish a therapeutic relationship when a person comes to your institution, where your institution has cachet for them. And so before the person even walks in the door, they think something, they expect something to happen. And then you do something and you show concern and you accept them for treatment. And these relatively neutral maneuvers turn out to have quite powerful effects. And that was where you got to the first edition. I can go on about the next step, but is that...
Well, we'll stop there just for a second,
Yeah.
but we do want to get into this in greater detail. I mean, what you described is so integrative. He had the training in medicine and psychiatry, the psychoanalytic training, and then the work with Lewin, which is, Lewin was the social scientist in that day. I mean, it was groundbreaking work that Kurt Lewin did. And then, we'll talk about how you and I got together, but the curiosity he showed about how psychotherapy works. While other people were busy developing a particular brand of treatment and claiming that this is the way it works and how understanding psychopathology, and we have to address particular psychopathology, your father looked at this in the holistic way. What is it about the context, about the common features, about what happens within sessions and the relationship that makes this work? And if you look at it in the context of the day, absolutely groundbreaking. So I didn't know the part about the anthropologist in California, which makes perfect sense because there's this in the book, a examination of what makes healing practices work across cultures and across practices, which is important to understand to do this. So, along the way, there were innovations that I think we should just mention that are so important. When your father started the research, it was the psychoanalytic tradition. We can't do any assessment of the patient. Only the therapist can report about the therapist's progress. And the development of the Hopkins symptom checklist was so critical. No, we have to actually measure the symptoms of the patient to know whether they're making progress. And often we don't give credit to how innovative that was. And then there was the clinical trials. If there was some aspect of psychotherapy that needed investigation, the group at Hopkins designed some innovative experiments. We could talk about some of these in detail, but they're absolutely fascinating to be able to isolate these particular factors. For me, I get irritated when people say, well, there's really no experimental evidence for hope and relationship and the alliance. And I said, well, that's not really true. Read the Hopkins group and you'll see clinical trials investigating these various components.
Well, also, I think what's very important is to included observations of what people were doing in therapy compared to what they said they were doing. So some of these things you couldn't be tried, but if you've watched, for example, they took transcripts of Carl Rogers's supposedly utterly non-directed therapy and analyzed them and was able to find that it was crystal clear what Rogers was thinking and doing and what he reinforced and what he ignored. And he thought he was being completely neutral. He wasn't being neutral at all. And that, so it wasn't just clinical trials and controlled experiments, it was also empirical observation that was, you know, not widely shared, but I think in some ways the most compelling stuff because it was about how people influence each other in ways they don't may not know what they're doing.
Mm-hmm. Mm-hmm. Yeah, interesting point, because so much goes on in psychotherapy. And as therapists, we tend to focus on what we're doing and think about what effect it has. But then for an observer who looks at this critically, there's a much more going on in the context than we think as therapists. So it's also interesting, some of this research and how it gets forgotten over time. The induction to psychotherapy and its effect on outcomes is really important, but you rarely read about that today.
Well, you don't read the
And
experiments, but it's actually built in or baked into many therapeutic protocols. CBT, and again, we talk about this in the book, but CBT therapists, when they are observed, spend a lot of time explaining what they're doing in the method. IPT therapists, it's part of the protocol. And now these third wave therapies that people are out, it's already there. It's no longer talked about as experimental data, but it's very, very commonly practiced, I think.
yeah, interesting. So the psychoeducation that
And
you
also,
find.
people get information off the internet now. I mean, people come in with some of this preparation often, because it's not just in the head of, some tomes in the library or the head of some eminent theoretician. It's out there in the culture, what these therapies are, what they do, and all like that. I mean, that information is not necessarily the same as what a therapist would share, but it still kind of lays the groundwork.
But even then, I think maybe because of that, even more important to explain what we'll be doing in therapy and how it is going to be helpful in achieving the patient's goals. I mean, the explanation of the rationale for treatment is so important. I train therapists, and I often ask them, if I were to go and ask the patient to explain how what they're doing in therapy will help them achieve their goals. If they can't answer that question, you haven't done an adequate job of explaining what we do in therapy and how it's tied to making progress.
And that applies to medication treatment too. Absolutely, not just take this pill and you'll feel better, but this is why I think this will help you get to where you need to be. I mean, people don't come in just because they have symptoms that they want control over.
Well, some of the research we've done and others have done, the psychiatrist prescribing the medication makes a difference. So what the psychiatrist tells, or the physician, whoever does the prescription, what you tell the patient is absolutely critical to the success. We know much of the effect of psychotropic medication is from expectations, and the expectations come from the relationship with the provider and the explanation that the provider gives.
And again, the book contains many, many, many examples of this because my father was a medical doctor. He treated patients who were referred from the medical services at Johns Hopkins, just as much as was concerned about their outcome as well as everybody else's. And so the role of the placebo as both a research tool and as an element of clinical care is front and center in our discussion.
So the first edition of Persuasion and Healing was 1961. And then the previous addition to ours was, and now I'm kind of blocking. When was
There
the,
were two. There were two,
yeah,
1977 or something, and then again 1991.
1991, that's right. So let's tell the story about how we got together and decided to update the 1991 edition.
Well, my father had died in 2005, but he had endowed a lectureship at Johns Hopkins in psychotherapy, and you came and gave the Jerome Frank lecture, and you talked, I thought, so wonderfully about this program of the hospital in Finland that you consult to, and
Yeah,
how they
Norway.
Norway, sorry,
Yeah.
Norway. Finnish is even more impenetrable than Norwegian, I guess.
Yeah.
About how they employ all of the insights that seem to account for the benefits of therapy to quite sick patients in a hospital setting, and I was so taken with it that at this point I was beginning to think, oh, I know, and at this point I had heard from the publisher that the book was still selling and they couldn't figure out why. This was now 30 years after the first edition and 10 or 15 years after the second edition. And somebody at the publisher called me and said, why is this book still selling? And I said, well, it's got some important ideas in it. And they said, would you like to revise it? Since I was the second author on this third edition. And I said, I can't. I'm not a researcher. I don't practice. I practice psychiatry, but I'm not really consider myself all the time psychotherapist. But then I heard your lecture and the penny dropped. And I said, if I could get a collaborator who understands this stuff as the way you seem to do, maybe we could do it. And so I recruited you to do what the publisher and I had asked me to do. So that's how it came about. And the program at the hospital in Norway is all about addressing, the context, measuring people's progress, meeting them where they are rather than just, squeezing them into diagnostic boxes. It tends to their sort of spiritual and general well-being as part of their treatment. The social factors of their family involvement are there. I mean, it all just sounded so lovely. It sounded a little bit like the way milieu therapy was meant to be when my training, but it was so much more better thought out that I was just very, very impressed.
Well, it really was the Wampold Psychiatric Center in Norway really embodied the principles of persuasion and healing. I mean, it was a humanistic context. It's a rural hospital, beautiful rolling hills and great light. Some of the famous Norwegian artists used to go to that valley to do their paintings. The director of the hospital would greet every patient group as they entered and praise their courage for seeking out this intensive treatment. Relationship, of course, was absolutely critical. There were spiritual activities, art, nature walks, but there was also the latest evidence-based treatments. So the patients understood what they needed to do to recover. And, I should say these are patients who have, well, in the United States, wouldn't have access to the kinds of treatment they get in Norway.
Certainly not in one setting, not so well organized and coordinated. Because people only stay there for, I think, 3 months or something. I mean, they're able to put it, as I understand it, into a fairly tight frame.
Yeah, various lengths depending on the unit. But these are people who have been out of work or difficulty in relationships for most of their life. And in Norway, of course, a social support network. So they weren't homeless that they might be in the United States, but they weren't functioning. And the recovery rate, quite dramatic, back to work, back to integration into society. But it was really this combination of the humanistic elements and the very deliberate work. And, they had psychodynamic depression unit. They had a cognitive behavioral anxiety unit. So there were a variety of treatments. But as your father said, the treatment really wasn't the critical part in the sense that there could be different kinds of treatments. But they understood exactly what they needed to do and participate in these actions to overcome their difficulties. So I get excited to talk about this because
Well, it was exciting to hear it.
Yeah.
I should mention, by the way, that in between, and I really was wonderful, but in between the 1991 edition and when I met you, and I had tried to provide another updated book, again at the request of the publisher. We called it The Psychotherapy of Hope. One of my father's dear colleagues, Renato Auerhahn, who was kind of a cultural psychiatrist, co-edited it with me. It was chapters on each of the different, based on the chapters of Persuasion and Healing. That book didn't do so well, and I think it's because the publisher wanted us to update it like a textbook, and talk about what's new in cognitive therapy, what's new in dynamic therapy. But there wasn't, people were still stuck in the old paradigms of, cognitive therapy works because of this, or, only psychoanalytic therapy works. And so that, even though that book is, got some very good things in it, it didn't have the coherence or and it also sort of said we need to go back to the original. We couldn't just try to update what we had done, and the original arguments are internally consistent and clear and data driven in a way that a follow-up book like that couldn't be, I felt anyway.
Well, we should mention you asked me to write a chapter for that book, and so
So you did. I forgot that.
Yeah, so I knew your father's work from Persuasion and Healing, but to write the chapter, I had to go back and read the research that they had done at Hopkins. And that's when it really struck me that your dad's curiosity about how psychotherapy works was so pervasive in his career. He wanted to understand how this worked. So let's talk about a few of the aspects about the book that people might find controversial or object to. And so when I talk about persuasion and healing, the aspect that people sometimes question is this idea of myth and ritual. Well, the myth, can you just make up any kind of explanation for somebody's disorder and that's going to be sufficient? And the ritual, can you do any kind of ritual and it's going to be effective? So how do we respond to the criticism that it makes psychotherapy look like some kind of healing practice that could be found anywhere in the world and not something that's scientific and evidence-based?
Well, partly the myth has to make sense in the context of the culture. And so in our culture, scientific proof supports myth. I think that's part of it. That, you can't just say any old thing. You have to have an origin story for what you're doing, why you think this will work, how it fits into our beliefs about people and how they interact with others and so forth. So not any old myth can work, but it depends who you are and where you are. I mean, you're not going to. Andrew Solomon, for example, who is a man who's written a long time about very severe depression that he has suffered from on and off all his life, and he subjected himself to an indigenous healing ritual based in a, like we describe in the book, this was based in a completely different cosmology than his own. His cosmology was very empirical and Western and so forth. And he went to somewhere in Africa and saw a shaman to see if he could be cured for his depression. And he underwent a ritual very similar to what's in the book. He was wrapped up in sheep guts, and he had to prepare for this, and he was made quite ill by it in some ways. And the shaman talked to him at great length and elicited his story at great length before prescribing what to do and so on. And he didn't experience a miraculous cure. On the other hand, he felt a lot better. And he said that, and he looked, and the things that made him feel better were very similar to the things that my father had noticed. He was part of the ritual involved being altruistic, helping other people, serving them a meal. Part of the ritual involved, again, a intense conversation with the shaman over a period of time. It was involved in the preparation and the expectation that something good could happen. So it's not that any myth works, but it is true that if you look at whatever it is we think we're doing, there's other elements that we don't recognize, because it's like the water that surround in the fishbowl. The fish doesn't know the water is there.
Yeah.
We don't realize necessarily that our belief in science and the authority of charismatic formulators of psychotherapy like Aaron Beck, like Albert Ellis, like Alfred Ellis, like Sigmund Freud, that influences human behavior. So that's part of it. The ritual also, I think, our rituals of therapy are really parallel to medical treatment rituals, for better or for worse. Sometimes I think that's really worse. But because that is so deeply ingrained in what people expect to be helpful. I mean, there are lots of people who don't respond to psychotherapy, but who do very well in religious therapy, or doing a religious healing, or seeing a counselor, or taking a hike to the top of a mountain in the Sierra Nevada. I mean, there's many different healing experiences in the world, but for psychotherapy as a professional treatment, our rituals are very much in line with what we do in medicine. And I think that gives them power and orients people to what to expect and respond. To the extent that they differ from what happens in medicine, that can be a problem sometimes. People expect you to do something to them. They used to, and anymore. And you don't. You say you have to do things for yourself. So you negotiate how does your ritual fit their problem. But it's not just any old ritual, and it's not and there's truth in every theory. But the truth is different from sort of the material cause and effect proof that we get from a lot of basic science.
Yeah, well said. I mean, one of the fundamental points you're making is that understanding how myth and ritual lead to healing is a scientific pursuit. So there's nothing unscientific about studying the influence of these practices on our well-being and mental health.
Right, and there are many more tools for doing that now, I think, than there were back in the 1960s. Well, it's just a wealth of data, observational data, as well as measuring people, what they say and what you observe others do. That has become far more common, I think. Excuse me.
And the ritual is important, as we discuss in the book, because it's action that is enacted in order to reach goals. So we're doing something, and we attribute our progress to the hard work we're doing in therapy. I mean,
but it's also interesting that one of the things Dad was of course Dad part along before he could talk about this, is what does having everything come virtually or through the internet, how does that support, what myths are behind that, and what rituals are involved in virtual care, and how do we study or understand their effects? Because they're there for sure, and people interact with screens so much in their lives. They expect instant feedback. They expect they feel like the AI bot understands them even when it doesn't. All that is, I think, going to have implications for how psychotherapy progresses in the future.
Well, we are in a brave new world in terms of relationships, not just psychotherapy relationships, but multiple relationships. But, in support of what we do, the alliance between the users of various internet protocols is important to the outcome. So belief that there's a person there who cares for us, and belief that the ritual, the treatment protocol, will be effective are related to outcome. So the same principles are there, but in a very different way. Is fascinating.
Yeah. I mean, I think
So
the medicalization of the ritual, though, is a problem because of the way it affects we diagnose people and so forth, and the way we often do intervene with medications and so forth that may or may not be really tied to what's actually going on in their brains. I mean, what we think is going on in their brains is also in some ways a myth because it doesn't directly explain what's going on with the person. We think it does, but it really doesn't.
yeah. Well, we know that much of the effect of antidepressants, for instance, is a placebo effect. It's the expectations. But, I want to talk a little detail about one of the studies that your father and Lieberman did around um, uh, relapse. And they found very clearly that if you attribute your progress to your own hard work, you relapse at a much less level than if you attribute it to an external agent. So if you think you're taking a pill and that's the cause of remission of your depression, when you quit taking the pill, remission rates are high. So the attribution of our progress to our hard work, and psychotherapy is hard work, and I think the relatively encouraging maintenance rates for psychotherapy are really attributed to this idea that we're working towards a goal, and we know how what we're doing is related to the outcome.
Well, my father, though, would say yes, but not always. I mean, there are psychotherapies that are much less. He had an Indian colleague named Shashi Pandey, and he was saying, if you just sit under a tree and have a rewarding time with somebody, that is healing too. So I mean, our notion that you have to work up a hierarchy, you have to do hard work and have an outcome, those are Western ideas. They're very powerful and they seem to affect people, but they're not necessarily the only thing that works or that helps.
So, kind of this idea about the protocols are kind of a Western idea,
Absolutely.
and people do change in various different ways.
Yeah, and even some Western therapies are not presented to people as making an effort. They still do, but they don't do it sort of consciously. Or they're not made. They don't. They may or may not. They may attribute, for example, the therapist may think that what cures them is the insight or something that you produce in the therapeutic session. Although it's clear that what maintains improvement is what goes on afterwards. If your relationships change, if your general adaptation changes in a positive way, you're much less likely to relapse than if you just make progress in the context of the therapy, but it's contained within the frame of the therapy.
Well, a point, and maybe we're getting off of the book a little bit, but it's related to what you said about various different ways of change. One of the principles you talked about was this psychotherapy induction, explaining what we're going to do in psychotherapy as a prelude to actually doing it. So building kind of the basis of the rationale. How do you explain sitting under the tree as a change process?
Again, this is, we are a little bit off the page, but I think it's, because in the context of an Indian worldview, that becomes a therapeutic thing to do. That just being next to you, I don't know. I mean, Dr. Pandey is long dead, but he sort of conveyed the idea that in India, that was considered to be healing, but I'm sure there would be preparation. You would choose what tree, what person, why you were doing it, what was the meaning. Maybe you were, aligning yourself with natural rhythms that are important to your well-being. I don't know exactly, but I'm sure that there was some sort of mythic uh, structure beneath that, so that made that work for some people, and nothing for everybody.
Important point, and that is we have to understand the cultural context of what we're doing. And many of our explanations, you said, are based on Western conceptualization because we live in the West. But often we have patients who have various idiosyncratic or cultural beliefs about mental health. And it's important to understand that context to design and explain the treatment. I mean, we might do CBT, but with a very different explanation for somebody whose cultural group is not rational and thinks about mental health from a spiritual or a religious origin.
Well, you don't even have to invoke that difference. I mean, we say you're going to do CBT because you have so much anxiety and here are your symptoms. But maybe you're an abused wife. And maybe having been in an abusive relationship has made you doubt yourself to such an extent that you're sort of frozen and at the mercy of experience all the time, and you don't feel you have any control. So you say, with CBT, we're going to help you understand how you lost a sense of control and what you need to do to restore it. So you don't that it's not, the myths are not just the myth. The myth, it's not just myth. It's personal understanding of how the person has come to the point where they need help, and how that relates to what you think you can do with them.
Mm-hmm. Yeah, very important. The understanding of the particular context for this particular person is so important, both for maybe choosing the treatment, but also in the explanation you give for the particular treatment. Yeah.
And also, I think we do people a great disservice by diagnosing them according to the DSM, because the DSM is meant to be acausal. It's meant to be observational, so it can be tested, and has some value, but it doesn't explain to people. People tell us why they are the way they are. They tell us what they think has caused them to end up where they are, and we don't listen. We don't ask enough about their explanation of things, and then we don't tailor what we do. And good therapists of every kind do that and do tailor what they do to what the personal context that the patient brings. And I think, again, that has a mythic element, because it says the therapist is channeling these forces above me to my particular case because they understand me. They understand why I got this way. So now all these basic principles of healing can be brought to bear to me personally. And I think that's a very powerful message.
Yeah, well said. Very well said. Well, Julia, we're running out of time here, and I just want to say it was wonderful to have the opportunity to talk to you today, but the invitation to be part of Persuasion and Healing is a capstone to my career. To be associated with Persuasion and Healing, with your father, with you, just brings joy to me, because what's said in the book is so important for therapists of all persuasions to understand. And so I guess I'm giving a plug for our book because I think it's so important. But please, even if you're an orthodox CBT or psychodynamic, understand the principles that make psychotherapy effective across the various approaches is absolutely critical to being an effective therapist. So again, thank you for the invitation, and thank you and your father for the previous editions and the insights.
Well, and thank you for making it possible for me to fulfill what I feel is a lifelong obligation to, express and employ and honor these principles. It wouldn't have done it without you.
Yep. So, thanks. And, well, I don't know if there'll be another edition, but there's so many important things that need to be understood. So, to the future.
To the future. There's things, by the way, we haven't talked about that we might talk about some other time about, demoralization and all like that.
Yeah. Yeah.
Okay. Well, it's been a pleasure talking to you too. Always good to see you.
Thank you, Julia.
Okay, that concludes this very special episode of the Making Therapy Better podcast with Bruce Wampold. We hope you'll stay tuned for the rest of Season 3. We have a lot of exciting guests coming up and can't wait to share that with you every other Wednesday morning on wherever you get your podcasts. And as always, today's podcast was brought to you by CarePaths EHR. Are you a clinical supervisor or do you run a training clinic? CarePaths is a comprehensive electronic health record system built with you in mind. Research shows that therapists get better outcomes and improve more over the course of their careers when they regularly measure their clients' treatment progress and experiences in therapy and then discuss those measures collaboratively. Along with a host of other features, CarePaths makes it easy for therapists to integrate measurement-based care into their practice with just a few clicks. Head over to carepaths.com now to learn more about our EHR system designed with training clinics in mind, and join us on the path toward making therapy better. Thanks so much for joining us. Take care of each other. Take care of yourselves. We hope to see you next time.